Good evening, everybody. We're going to be starting the webcast in just 1 minute. Just waiting for everybody else to join. All right, we're going to get started this evening. Welcome to the Leukemia and Lymphoma Society of Canada's webcast, Progress in Understanding and Treating Non-Hodgkin Lymphoma. Today, Dr. Robert Kreidel, a clinician scientist at Princess Margaret Cancer Centre, will speak about how our understanding of non-Hodgkin lymphoma is steadily increasing and how this knowledge can be translated into novel therapies. My name is Catherine. I'm the Community Services Manager for the Prairies at the LLSC. I will be the host of this online event. The presentation will last approximately 60 minutes and will include a question and answer period at the end. Since there are many of you, we invite you to type your questions and comments in the question box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions. I will read some of your questions aloud at the end of the presentation during the question and answer period. This conference will also be recorded, therefore you can listen to it again on our website. Before we begin our main presentation, I would like to share with you our mission and highlight some of our resources that might be helpful for you or someone you know. Next slide, please. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer guidance and support every step of the way. We know the current situation presents many challenges to those affected by blood cancer and their families. The community services managers can help. They are compassionate connectors that can help you cope with your blood cancer experience. Please do not hesitate to contact a community services manager in your area. Next slide, please. Last November, we launched our brand new website, bloodcancers.ca. The website was designed with you in mind to ensure easy and personalized navigation, no matter your current circumstances. For example, if you've been diagnosed and are living with a blood cancer, you can choose, I have a blood cancer. It's a link at the top left-hand of the page. There you can choose information by blood cancer type and subtype. The pages are designed to provide you with easy access to services and valuable information in various formats. Next slide, please. Here are some examples of education resources and support services you can find on our website. Access to free booklets and fact sheets containing information about specific blood cancers, treatments, and practical information. You can also find animated educational videos, past webcast recordings, as well as access to all of our podcasts. Next slide, please. Our peer support program is a support service that matches people affected by blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by a blood cancer and shared similar experiences. Whenever possible, participants and volunteers are matched based on their age, gender, and diagnosis, or the issue that is most concerning to them. Contact the community services manager in your region to learn more. Next slide, please. It is my pleasure to introduce our speaker today, Dr. Robert Kreidel. Dr. Kreidel is a clinician scientist at Princess Margaret Cancer Centre. His research interests include lymphoma genomics and their correlation with treatment response, as well as the discovery of novel therapeutic approaches to improve patient outcomes. He completed his medical training and medical oncology residency in Belgium and Switzerland and obtained his PhD from the University of British Columbia. Thank you for being here today, Dr. Keidel. Over to you.
Well, thank you, Catherine, for the introduction. And I would have to say I'm extremely honored to be here. It's my great pleasure to be giving this webinar. And I have to say the LLSC does an amazing job at supporting our patients, but does also a really amazing job of funding really critical research across Canada for blood cancer. So I'm very happy to be here. And so it's asked to give, I think, a general overview of what non-Hodgkin lymphoma is, and talk about some of the new treatments that we consider for this really group of diseases. And then at the end, we'll have hopefully plenty of time for questions. So, so first of all, what is non-Hodgkin lymphoma? It's a bit of a mysterious disease, right? Oftentimes, or sometimes I hear and ask people in the family or family patients, and sometimes people get confused by lymph nodes being enlarged, and that doesn't always mean that it's a lymphoma, right? Because lymph nodes can be enlarged for many different reasons. And then, of course, certain other cancer types can cause enlarged lymph nodes, but that doesn't mean that a given patient then has lymphoma. So essentially, non-Hodgkin lymphoma is really cancer of the lymphatic system. So it's a cancer from that arises from within the immune system, from a very particular type of blood cell that we call lymphocytes. And there's many, many different types of lymphocytes that can give rise to the various subtypes of non-Hodgkin lymphoma. And essentially, we'll come back to that. The fact that the lymphatic system is not a confined organ, but is present throughout the body, means that patients can present with symptoms and signs in various parts of their body. And it makes our specialty very different, for example, from cardiology, for example, where it's more focused on a given organ site, whereas we really have to look at the entire patient and the entire body. So as I mentioned, the symptoms can be highly variable from patient to patient and also depend on the specific subtype of lymphoma. And oftentimes, actually, patients come to have no symptoms, and this is particularly true for patients who are diagnosed with indolent lymphomas. And on the other hand, probably the most typical symptom or sign that does lead to the attention of a lymphoma physician is the observation of having enlarged lymph nodes that are oftentimes palpated, for example, in the neck, in the armpits, in the groins, that can also be found deep inside the body, in the chest, or in the abdomen. Certainly, lymphomas can cause very general symptoms such as fatigue, and then we oftentimes ask our patients whether they have any of the B symptoms, which is really fevers, night sweats, and weight loss. And the night sweats that are characteristic of lymphoma typically are drenching. It's more than the little bit of sweating at night when it's a bit warm. It's really drenching night sweats that is not a normal situation. And weight loss also typically is considered a symptom only if it is more than 10% of body weight. The whole hematopoietic system can be involved, and that includes the bone marrow, so the space within the bones in which the blood is produced. And if that space is occupied by lymphoma, then there's less space for normal blood cells to do their job, and that can lead to low blood counts and associated symptoms, which can be anemia, infections, or a risk of bleeding. And then we have certain lymphoma subtypes that are really a specific predilection for specific organ sites. For example, there's a thing called brain lymphomas, which we refer to as primary CNS lymphomas that, of course, affect the brain. Skin lymphomas, as the name says, it affect the skin, and so forth. These are just two examples out of many. Diagnosis is very important, of course, because there are many different subtypes of non-Hodgkin lymphoma, so the accurate pathologic classification is very important. So, and what really is needed is a good biopsy. And typically, the gold standard or the ideal biopsy is a biopsy in which a surgeon goes in and takes out either a piece or an entire lymph node. However, that often then is more difficult or takes more time to do, and many times our patients actually have a diagnosis established based on a needle biopsy from a lymph node. And the needle biopsy also has the advantage that it can be taken from organs deep inside the body, and our radiologists typically are extremely skilled at doing this in a way that really minimizes discomfort to patients. Certainly, diagnosis can be established in other ways. There's particular types of lymphoma that are found predominantly in the bloodstream. In those situations, of course, it's very easy to take a blood sample and analyze it, find that there's evidence of lymphoma. And then there's, of course, imaging studies, most typically CT scans, but very often also we do PET scans, which are a more refined way of doing CT scans that use essentially a form of glucose, the sugar, that lights up all the areas that are involved by lymphoma in the patient's body. It's a very simplified classification that, however, is important just to draw the overall picture of lymphomas. So we are not talking very much at today's webinar of Hodgkin lymphoma, but Hodgkin lymphoma is a very distinct and unique category of lymphomas. It's only about 10% of all lymphomas, and it really goes down back to a person called Dr. Thomas Hodgkin, who was a British physician, and in 1832 he reported the first case series of patients with Hodgkin lymphoma. And since then, every single lymphoma would either be called a Hodgkin or non-Hodgkin lymphoma. Non-Hodgkin lymphomas, which are really the majority of all lymphomas, they're categorized into mainly two categories, the B-cell and the T-cell lymphomas. And the B-cell lymphomas stem from a very particular type of lymphocyte called the B-cells. And those are the cells that typically make antibodies to protect you against infections. And the T-cell lymphomas similarly come from T-cells. And either of these two, either B-cell or T-cell lymphomas, can be indolent or aggressive. And the most common lymphoma of all that we treat is called diffuse large B-cell lymphoma, which is an aggressive B-cell lymphoma. And the most common indolent lymphoma is called follicular lymphoma. And then, of course, there's many more subtypes that are less common. One that is sometimes a bit distinct is called chronic lymphocytic leukemia or small lymphocytic lymphoma. That is a sort of indolent B-cell disease, and oftentimes can present mostly as a leukemic form with circulating tumor cells in the bloodstream. And the indolent and aggressive distinction is quite important because most patients with indolent lymphomas tend to have a lymphoma that progresses very slowly, sometimes over many years. Oftentimes, these patients do not really have many symptoms when they come to our attention. And oftentimes, actually don't necessarily need treatment up front. And then on the other hand, patients with aggressive lymphoma typically tend to need treatment up front, but actually there's a chance potentially of curing those sort of lymphomas with chemotherapy. Treatment planning, I only put 4 bullet points down with very few words because, of course, that really depends a lot on each individual patient's situation. Certainly, the specific lymphoma type will indicate what treatment is indicated. Certainly, there are factors that are specific to a given patient, such as the stage of the disease, the clinical presentation, whether there are symptoms or not. And then, of course, very importantly, the patient's fitness, or maybe the corollary, which can be frailty sometimes. So we pay a lot of attention on comorbidities, and we ask not just the question, what is the benefit of a given treatment, but what could also be the risks, and how do we balance this out when we make a treatment decision. Drug therapies are quite variable. One approach that we often choose for patients with indolent lymphomas is what we call observation or watch and wait. I find that many of my patients have, at least at the beginning, quite a bit of difficulty accepting this because it's difficult to know that you have a tumor about which we are not actually doing anything about. So sometimes the watch and wait can more be a watch and worry approach for our patients, but it's nonetheless a very valid strategy and actually forgoes the need for treatment that can also have side effects. And we only really consider observation if we are convinced that based on the available evidence in the medical literature that it is safe to do that. We are not kind of taking any risks for our patients. And then on the other hand, for patients with aggressive lymphomas, we typically always recommend treatment upfront. And here the aim is really to potentially cure the disease, hoping that it goes away once and for all, that it does not come back at all. The treatment, of course, the most typical treatment that everyone thinks about when we talk about treating cancer is chemotherapy. It has been around for many decades and still is doing very useful service because many patients still nowadays are cured with at least treatment that contain chemotherapy. And certainly we are working on finding more innovative treatments that have maybe fewer side effects. But chemotherapy is not about to go away for most patients because it can be very useful treatment that applies to many different lymphoma types. Many patients these days, and almost all patients with B-cell lymphomas get treatment that will contain this very specific antibody called rituximab or newer versions of this antibody. And that is really based on advances that we've seen for the last, I would say, 15 to 20 years. And it's really significantly improved the outcomes of patients with both aggressive and indolent lymphomas. Radiation is in a way a very simple treatment. It's a local treatment that can be given to a very specific area of the body and can be given at lower doses, higher doses, and has roles to play both in the attempt to cure patients, but also in attempt to kind of provide relief of certain symptoms. And then, of course, we have targeted therapies. And one example, but there are many examples, it's probably one of the oldest targeted therapies that we have been using is called ibrutinib. And those therapies, they're oftentimes taken in the form of pills, but not always. And they usually target a very specific molecular pathway in the tumor cells, which is a bit distinct from chemotherapy. We have, of course, stem cell transplant. We'll have a slide on stem cell transplant. And then we have further innovative treatments. And one type of treatment that is really in the news a lot is CAR T-cell therapy, which is an example of an immune effector cell therapy. I will come back to that later. The stem cell transplantation can be done in mostly two different ways. In the first, and that is the one that is mostly used for patients with lymphoma, we call this autologous stem cell transplantation, and that is opposed to the allogeneic stem cell transplantation. And the difference really is that for the first one, the autologous, the stem cells are derived from the patient themselves, whereas for the allogeneic stem cell transplantation, the stem cells are derived from a donor. That can be related or unrelated, but it's not the patient themselves. And autologous stem cell transplantation is sometimes or frequently used for the treatment of relapse from certain type of non-Hodgkin lymphoma, such as diffuse large B-cell lymphoma, but also Hodgkin lymphoma. And it's really just a way of giving high doses of chemotherapy, and it's a way of kind of shortening the duration of side effects that would be seen otherwise. This cartoon illustrates the process quite nicely, I found. You can see on the left a patient is installed in a chair, and there's an apheresis machine that allows us to collect the stem cells into a bag. These stem cells are then frozen down. When the patient is ready for their treatment, they come in, get the high dose chemotherapy that is meant to kill all leftover tumor cells off. And then eventually the patient receives the stem cells that are just stored in a water bath, and they're reinfused back into the patient's body and then find their ways into the bone marrow niche. I won't talk too much about the allogeneic stem cell transplantation because that is really currently no longer used very often for non-Hodgkin lymphoma. CAR T-cell treatment is a bit of a science fiction type treatment, and it's kind of amazing that it works. It has allowed us to make tremendous progress in the field, and it's a bit more complicated. So here we take still cells out of a patient called T cells, and they, however, then get not just frozen down, but they get modified. So they get modified to express this CAR, which is a receptor that is meant to bind to the patient's tumor cells. So in the laboratory, essentially in a plastic dish, these cells on the patient get modified so that they can actually be directed against the patient's tumor. They get expanded in the dish, and then when the time comes, they get reinfused back into the patient. And it's actually really not a passive treatment at all. It's a very active treatment because once these cells come in contact with the cancer cells, they actually get activated and expand actively within the patient's body, which is both what we actually want, because you want these cells to really grow like into a very large army and fight the tumor cells off, but can also be associated with certain side effects such as inflammatory responses and sometimes neurological toxicity. Clinical trials are extremely important to help us define the new efficacious treatments. And of course, they're normally preceded by sometimes long periods of preclinical discovery, where scientists and research labs formulate hypotheses and then try to understand the fundamental principles of biology and cancer biology and try to identify ways of curing first cells in a dish, then maybe mice, and then subsequently hoping that these novel therapies can make it into patients. There's typically different phases of clinical trials reported, and the most typical phases we know are phase 1, phase 2, and phase 3. And I thought that this cartoon was quite illustrative because it shows you that phase 1 are normally small trials with few patients. Phase 2 trials a bit larger, and phase 3 trials can be very large trials, sometimes with over 1,000 patients. And typically, the goal of the early phase studies is really to, first of all, identify the correct dose that we should give to our patients, but also define that the drug that is being studied is actually a safe drug. And then once that is established, during later stage trials, typically it is a matter of identifying whether the drug actually is efficacious and oftentimes whether it is better than the current standard of treatment. And once the drug passes all these many hurdles and steps, it can potentially be approved by the regulator. The cartoon here says FDA. In Canada, of course, we have different approval systems, but the principles are the same. So what about side effects of the various treatments? They, of course, vary and depend based on what specific treatment is given. Chemotherapy, as you all know, can cause fatigue, can cause another complications such as infections, low blood counts. Sometimes patients do need blood transfusion, for example, to palliate those low blood counts. There can be nausea, which, however, is most often prevented with medicines that we give. There can be mouth sores. There can be other gastrointestinal side effects, such as constipation or diarrhea. Some chemotherapy drugs can cause nerve damage, which tends to, generally speaking, improve with time once the chemotherapy stops. Antibodies, on the other hand, have really quite different side effect profiles. They typically can cause infusion reactions, typically when they're first given, and subsequent infusions, these reactions tend to subside and make it easier to give those treatments. They can also cause immune suppression, and that is quite relevant, especially in the current COVID pandemic, given that patients who are receiving some of these therapies can get increased risk of having poor outcomes with a COVID infection. Radiation can cause, generally speaking, fatigue, irritation of the skin at the area of irradiation, and sometimes can also cause suppressed blood counts if, for example, the bone marrow compartment is included in the radiation field. And then, of course, targeted therapies, here really side effects depend on which specific drugs are given. They can be really very variable from drug to drug, so I won't go into too much detail here. Follow-up, very important, of course. So oftentimes we see our patients every, I would say, 3 to 6 months in the follow-up after completion of treatment. And these follow-up visits are really very back to basic principles of medicine, right? It's really a good history taking, understanding how the patient feels, are there any new symptoms potentially, how is recovery coming along. Certainly, physical assessment is very important to document whether there could be any new findings, in particular new lymph nodes. We certainly almost always look at blood work, make sure that the blood counts are improving after chemotherapy, for example, make sure that there's no other major abnormalities in the blood work that might potentially indicate that something is off. However, what we are not necessarily doing on a routine basis is imaging with, for example, CT scans. So oftentimes when patients have completed the treatment, we actually monitor patients clinically without doing routine CT scans. And that is really because we have shown that doing CT scans, let's say every 3 months on a routine or default basis, typically actually does not improve the outcomes of our patients. So it's not seen as a procedure that is really beneficial. And then certainly in the follow-up period, we pay a lot of attention to ensure that the patient reconnects with their family doctor. Oftentimes when they are with us for the treatment, there's many visits, sometimes visits every week, every 3 weeks. And so by the time the treatment is completed, it's really time to reconnect with the family physician and sometimes other specialists who may be involved in their care. So long-term and late side effects are very important to recognize and sometimes are not sufficiently recognized and understood. I would say, in order to keep it simple, that most of the common long-term side effects, they actually tend to improve with time. So oftentimes the fatigue that kind of can linger after treatment, or let's say the immune suppression, or what we sometimes refer to as the chemo brain, which is typically the difficulty to concentrate, or even the neuropathy, the nerve damage, those are things that tend to improve with time as patients continue with their recovery. And then some of the long-term effects that are listed at the very bottom, such as toxicity, for example, for the heart that is seen with certain chemotherapy drugs, or late cancer that may be related to chemotherapy, they're fortunately rather uncommon, but of course, very important to recognize early. Survivorship is very important as well, and at our hospital, we have the luxury of having a dedicated survivorship program to which we normally refer our patients once they've completed their treatment. But it's really a very holistic approach to look at our patients and ensure that all components that are necessary for their well-being and their functioning are taken into account. And so this certainly starts with their psychological well-being. That certainly also starts not just at the survivorship step, but much before. But nonetheless, sometimes once the acute phase of treatment for lymphoma is over, there can sometimes be more uncertainty, sometimes the fear of recurrence, anxiety related to this. So making sure that all these psychological needs are addressed is very important. Nutrition is also a very important component of survivorship, and there's not necessarily major principles other than just making sure that patients have a healthy, balanced diet, either to help us with recovery, but also prevent, of course, other diseases much later in life. Physical activity can be an important component of recovery and survivorship, and it certainly has been shown to actually speed up the recovery process. But of course, sometimes the fatigue can be so significant that getting back into having a physical activity may be quite challenging. But generally speaking, we encourage patients to remain active, even sometimes while they're in chemotherapy, to kind of avoid that they lose too much of their independence during treatment. Many other aspects that are being discussed during the survivorship consultations relate to return to work or school, sexual health and fertility, especially in the COVID context. We speak a lot about vaccines, and certainly also the prevention of other cancers. And typically that comes back to referring patients back to the family doctor, making sure that all the other screenings are being taken care of, because I certainly wouldn't want to have our patients miss an important screening and then have a late diagnosis of a cancer that otherwise would be preventable. So that's it for my slides. So I want to leave ample time for discussion, and I think Catherine and Sonia have actually already gone through some of the questions that were submitted ahead of time, so I'm happy to answer them as they come along.
Great, thank you, Dr. Kreidel, for sharing your expertise and insight with all of us today. As he mentioned, it's time for a question and answer period. So if you haven't done so already, be sure to use the Q&A box in our Zoom webinar panel to type your questions. We will do our best to get to as many as possible. So I'm just going to get started here with some of our questions. Been hearing a lot of successful clinical trials with CAR T cell therapy, but they're not currently available for all blood cancers. Will this be available soon in Canada?
Yeah, that's of course an excellent question. So CAR T cell therapy is already available in Canada for a number of indications. However, they of course at the moment still restricted to those indications in which CAR T cell was proven to be really beneficial and really improve patient outcomes. So CAR T cell is being studied currently in clinical trials for more and more indications, both indications that are kind of similar or related to the indications that are already funded, but also for indications that are completely distinct. For example, we talk a lot about B-cell lymphomas, and CAR T cell for now is approved exclusively for certain B-cell lymphomas, but research is going on to study CAR T cell also, for example, for Hodgkin lymphoma or even for T-cell lymphoma. So that is certainly an area of major and rapid expansion. And I think the way we'll practice this medicine in 10 years from now will be very different from what we are doing now, as far as I can tell.
Okay. How often should an oncologist do CUT scans to monitor cancer progression for those with a diagnosis of FNHL and CK?
Yeah, so as I was mentioning in one of my slides towards the end, so we don't do CT scans too often, but of course it's a bit of individualized decision, right? So, but by and large, studies have shown that doing, let's say, systematic CT scans every 3 months, for example, does not really help manage lymphoma, and nor does it improve patient outcomes. So of course, there can be some exceptions, especially for those patients who have, for example, disease that we can otherwise not palpate on clinical exam if it's deep inside the chest or the abdomen. So I think it can be sometimes a bit of an individualized decision, but by and large, we tend to not do those really systematic frequent CT scans, and this comes up in my clinic very often. But one has to realize that doing many CT scans can lead to exposure potential to radiation, can lead to incidental findings that have no implication whatsoever for the lymphoma care and can cause further anxiety. So, so there are several reasons why we actually don't do those CT scans on a routine basis. And I think much more important really is a good clinical assessment, taking good history. If there's typically no changes the way our patients feel, and even physical assessment, you don't identify anything worrisome that is changed from before, then oftentimes that is very reassuring, and we oftentimes can forego imaging in those situations.
Thank you. For those with follicular lymphoma, what would be suggested for relapse after a long remission, having received CBP and then developed Steve-Johnson syndrome after a single dose of rituximab?
Yeah, so relapse of lymphoma can be associated with many symptoms. And again, I was mentioning, the lymphatic system is so diffusely part of the body that relapse could potentially be manifesting as any possible symptoms. So, however, that is not very helpful to say. So normally what I tell my patients is that really any change of their health from their baseline that is unexplained should prompt them to seek medical attention, speak to their either family doctor or their hematologist. Certainly any new enlarging lymph nodes, any lymphoma that they may find in the neck, in the groins, for example, would be an alarm sign. And certainly if there was any general symptoms such as progressive fatigue, all of a sudden night sweats or rapid weight loss, those of course would all be reasons to seek medical attention sooner rather than later.
Great. Is stem cell transplant used in both T cell and B cell disease?
Correct, yes. So stem cell transplant is used for both B cell and T cell non-Hodgkin lymphoma. It's typically used for situations of relapse from these conditions, at least at our center. For T cell lymphoma, sometimes it actually has made its way into the frontline treatment algorithm in some centers, but there's still some controversy. But so yeah, for both B and T cell lymphomas for sure.
Is there any research that is looking at which COVID vaccination would be better for those that have had rituximab?
Yeah, that's of course a very timely question. So first of all, I have to say and reiterate that our patients suffer a lot from COVID, sometimes directly, but certainly also indirectly because of the immune suppression that is conferred by the treatments, and it really puts them at higher risk, which can certainly cause quite a bit sometimes of distress, and so kind of emphasizing that patients have all the vaccines taken up to the maximum allowed by the respective jurisdiction is very important, right? So that can go currently up to 4 vaccines based on when the treatment was given or maybe is still being given. So that is certainly something that everyone should discuss with their treating physician. Now, I don't necessarily have any data that would suggest that a specific vaccine is better than another. So the 2 vaccines that are mostly nowadays given in Canada, they seem quite similar in their efficacy. So either of those vaccines will be fine for our patients.
Okay, the same part of that question, what about those who have hypogammaglobulinemia and do not qualify for IVIG?
Yeah, so that is probably best to discuss with the treating hematologist, right? So just the documentation of hypogammaglobulinemia is not sufficient to start treatment with replacement immunoglobulins, because those treatments also have side effects that can potentially be severe. So typically, we do not give those treatments unless patients have run into one or maybe even two infections at least, which may be a counterintuitive thing to say, because I guess from patient perspective, it may not make sense that the physician expects that there are complications first, but the reality is that many patients with low immunoglobulins actually do not have infections. So it's not a treatment that we would give to anyone in that situation. It's really, again, an individualized decision. And I would say also probably important to discuss this in detail to kind of understand the pros and cons of giving such treatments and discussing with the physician.
Okay, so what are the long-term side effects of rituximab?
Yeah, so by and large, the side effects from rituximab, I would say, are not necessarily seen in the long term, but rather in the short term or midterm, and they mostly relate to the suppression of the immune system. And once the treatment with rituximab stops, and it always stops at some point, then of course the risk for infections kind of decreases, and the risk tends to go away after a few months. In terms of long-term side effects, there's some really rare complications described, but they're really at the level of probably case reports. They're really very uncommon, I would say.
Is there a causal relationship between non-Hodgkin's lymphoma and skin cancers?
Yeah, another extremely pertinent question. So causal, I am not sure, but there's certainly an association. So some patients with certain type of diseases can be increased risk of skin cancer. Maybe the most typical disease that comes to mind is chronic lymphocytic leukemia. But it's also the type of disease that tends to affect patients of a skin color that is maybe more prone to developing skin cancers. So I would say that generally speaking, anyone, but especially patients with a history of lymphoma, and especially if treatments were given, should pay attention to their skin. If they were to find any mole that is changing or increasing in size, or to start bleeding or anything like that, those would be alarm signs, and certainly would need to have them seen by a physician to look at the skin.
Okay. Now, can you tell us what is available for patients who are 3 or more years into partial remission?
Yes, it's a bit difficult to answer this, and I think it depends on the situation, right? So it depends on how the response was assessed, because sometimes the way you assess response, it can seem that it is a partial remission, but in reality, it could even be a complete response. It's just that our tests are not subtle enough to actually pick that up. And then it depends on the specific lymphoma type and how much it progresses, right? So there are many situations in which you do observe our patients without treatment, especially if there's stability, and sometimes just evolution in time helps us understand whether the disease may remain stable over time.
So what are things people can do to extend remission?
So yeah, so those are very important areas for research, of course, because almost all of our therapies, they are looking at improving outcomes, and that means extending remission. Now, what often patients ask me, and I think maybe that's what the question tries to get to, is there anything that the patient can do on a day-by-day basis to kind of reduce the risk of recurrence, extend the remission, and there's nothing that we really know about, right? So it's really just about leading a healthy lifestyle as much as possible, a balanced diet. There's no, unfortunately or fortunately, there's no mystery recipe someone can go after to kind of have an impact on remission. So I think our goal is really to have treatments that will become so potent that long-term remissions will be the standard for all of our patients.
Okay. Are there any new treatments after 2015 for Waldenstrom's macroglobulinemia?
Yeah, so Waldenstrom is again one of these diseases where there's been great progress, and we really seen that we already knew that chemotherapy was available and works to a large extent. But then there's newer therapies that have been reported, in particular those that target very specific proteins in the blood cells. And I think the progress has been made on several fronts, but sometimes the progress comes not only from developing a novel medication, but sometimes also from developing a medication that's a little bit different and maybe is slightly more effective, or at least has fewer side effects. So sometimes within the same class of medications, we see that as years go by, we actually have more than one type of medication we can choose from. And sometimes that gives a bit of flexibility to choose a drug that may be better suited for a given patient by having, for example, fewer side effects that may otherwise apply to that specific patient. So, but yes, certainly progress ongoing for Waldenstrom's disease.
Okay. What are the possible long-term side effects of new therapies?
Yeah, I saw that question ahead of time, and I knew I was going to have a hard time answering the question because as many of these therapies are new, we of course don't necessarily have the long-term follow-up that is needed, right? So I think this is something that we are carefully monitoring. And that said, sometimes late side effects are difficult to capture, right? Because you sometimes need 20, 30, 40 years to identify them. So, but I just, the overall field is progressing, and as we go along, we will be aware of some of these side effects that may arise. But overall, our gut feeling, though, is that with many of the targeted therapies, that we may potentially be avoiding some of the maybe the worst side effects that, let's say, chemotherapy could have after decades of follow-up, right? So, for example, those late secondary cancers is something that we hopefully would not see as much with targeted therapies.
Okay, so is there any data to confirm the efficacy of the COVID vaccine in limiting the severity of COVID in patients receiving rituximab?
Yes, absolutely. So, of course, there's no, the timing matters a lot. That is something that we have learned. So oftentimes when an immune reaction has happened and patients been vaccinated and COVID and so rituximab is given, that doesn't necessarily take away all the immunity. There's still some cells left over that can respond to COVID. Conversely, if we immunize a patient while they are receiving rituximab, the response to the vaccine can be quite low. But the general feeling, and the studies show, that even patients on rituximab, even patients on other immunosuppressive therapies will benefit from the COVID vaccine, and that the COVID vaccines will both reduce the incidence of COVID and also the severity of COVID.
So are GP doctors being informed or trained on ways of early detection?
Yeah, excellent point. So early detection is important for many cancers. For lymphoma in particular, maybe a bit less so. And it may again be sounding a bit counterintuitive because one would think that it is best to detect any sort of cancer as early as possible. But remember that many of those lymphomas are currently kind of really these indolent diseases that can be around for decades, and patients can sometimes live with them for 30, 40 years. So identifying them 5 or 10 years earlier may not always be necessarily beneficial. That said, I would say the family doctor's role is, I would say, primarily a role of prevention, right? Much of the preventative efforts in our healthcare system are really done through family physicians' offices. So in terms of preventing other diseases, cardiovascular disease, or improving early detection of breast cancer, colon cancer, oftentimes the decision to go towards screening actually come by the patient talking to the family doctor. So I would say family doctors are ideally placed to look at early detection of cancers in general.
Is Canada keeping up with and offering newer treatments for patients?
I would say my answer is clearly yes, but of course there's a little but. So generally speaking, we can give pretty much whatever treatments are approved in most other jurisdictions. There can be some exceptions for maybe the most recent treatments that are approved in the States by the FDA. Those may not be immediately available for our patients in Canada, just because our regulatory process is more slow, but it's also more slow because of valid reasons, because our healthcare system looks at approving drugs that have a certain level of efficacy and cost effectiveness. But generally speaking, some of those drugs that are maybe not yet available, they could be available via clinical trials or sometimes compassionate access programs. So it's really uncommon that I feel that our patients are missing out because a given treatment wouldn't be available to them.
Okay. Is follicular lymphoma curable?
It's a controversial topic. So first of all, follicular lymphoma can present in various stages. And when you look at patients with very limited stage disease who get radiation, we know that about 50% of them will remain in remission in the long term. So these are likely cured to some extent. And then we also know that patients actually receive chemotherapy for follicular lymphoma. About 50% of them can remain in remission after 10 years of observation. So I guess we need another 10, 20, 30 years of follow-up to determine whether these remissions are really sustained. But certainly we see that some, and actually many patients with follicular lymphoma can have really, really long remissions, and hopefully some of these will translate into cures. But it's really our job to kind of really increase that percentage of patients into this really long remission.
How common is follicular non-Hodgkin's lymphoma?
Yeah, so the second most common non-Hodgkin lymphoma, and we estimate about 2,500 new patients diagnosed with this disease in Canada per year. So it's not the most common form of cancer, but it's certainly not an uncommon form of cancer at all.
Should there be a relapse of mantle cell lymphoma after chemo, stem cell transplant, and maintenance rituximab? What is the next step?
Yes, it depends a bit on various factors, including the time of remission. Sometimes if the remission period is very long, then it may actually make sense to use a different type of chemotherapy to induce, again, hopefully a long remission. But mantle cell lymphoma is, again, one of these diseases where we have seen really great progress, and more we use more targeted therapies in the second-line setting. And there's probably in the pipeline, there's other therapies that will come. So again, here, that's typically a field where in 5 or 10 years from now, the drugs that we'll be using are different from the ones that we are using currently.
After having a stem cell treatment of own cells for NHL, mantle cell B, what is the prognosis? I've heard this individual's only heard of it only buying time, but how much time?
Yeah, I cannot really give one precise answer to this question. I think it is so dependent on each patient's situation. I think the risk of recurrence, of course, is not just random, right? It depends a bit on how aggressive the disease was before chemotherapy was even given. So I think that's probably something that is best discussed with the physician.
Can you provide an update on predictive oncology in clinical practice associated with blood cancers? For example, genomic level testing that matches the right treatment at the right time for patients?
Yeah, an area of active investigation, certainly on our end here. So I think we are not quite there yet, with some exceptions. So there are already examples nowadays where we actually look at genomic markers and then base a treatment on the genomic markers. And a good example, for example, is chronic lymphocytic leukemia. We look, for example, at mutations of a gene called TP53. We look at what we call FISH, which isn't the same thing that we eat, but it's a French technique to look at whether certain chromosomes are broken. And that allows us to identify those patients who actually for sure will not do well with chemotherapy, and we'll give them a different treatment. So those genomic markers are already available in the routine setting. However, for the majority of patients with lymphomas, we are not yet using genomic markers, but I think that is clearly an area of future expansion. This is going to change at some point. I don't know whether it will take 1 or 2 years or 5 years from now, but this is certainly something that will change going forward.
Okay, and our last question, what innovations exist in Waldenstrom's treatment?
Yeah, so similar to a question we already had. So I think it's really, beyond looking at beyond chemotherapy, looking at targeted therapies, looking at refined versions of targeted therapies to kind of both improve the efficacy of the treatments, but also reduce the possible side effects.
Thank you once again, Dr. Kreidel, for being here with us today. We really appreciate your time. We would also like to thank Janssen and Segan for helping make this webcast possible today.
Yeah, thank you. It was my pleasure. I'm sorry, I realized that the video kind of was cut off at some point, but yeah, thank you so much for the very kind invitation. It was a pleasure to be here.
Thank you. I would like to remind everyone that we are here for you. Do not hesitate to contact the LLSC if you have more information or support. You need to reach us by email at info@bloodcancers.ca or toll free at 1-833-222-4884. Also, make sure to check our website, bloodcancers.ca, to learn about upcoming webcasts, podcasts, and special events. Please note that a short survey will be sent to all participants after this webcast. We would greatly appreciate you taking a moment to fill it in, as it'll help us to offer you the most valuable information in the near future. From all of us at LLSC, we wish you and yours a wonderful day. Thank you.